Welcome to the Radiology Review Podcast, your on-the-go source for radiology education with your host, Dr. Matt Covington, a board-certified radiologist. Please follow the podcast on Twitter @RadRevPodcast. Send emails to theradiologyreview@gmail.com or visit the website theradiologyreview.com.
Welcome back to the Radiology Review Podcast. This episode is part 2 of my review of pancreatic masses for radiology board exams. A free downloadable study guide on this topic is now available at theradiologyreview.com. That covers the content on both part 1 and part 2 of pancreatic masses. Thank you for listening to this podcast. Check out the Radiology Review Journal for my recent post on why every medical student should consider radiology. And let me know if you have episode topic suggestions by emailing me at theradiologyreview@gmail.com or contacting me on Twitter or Instagram at RadRevPodcast. Without further ado, let's get into the questions and answers for this episode. First question, true or false? Pancreatic pseudocysts can be located within the mediastinum. The answer here is true. Pancreatic pseudocysts, if large and appropriately positioned, can extend through the diaphragmatic hiatus into the mediastinum. Next question. What are key features of serous cystic tumors of the pancreas? First of all, serous cystic tumors of the pancreas are benign. The most common are the microcystic pancreatic serous adenomas, and the less common are the serous macrocystic adenomas. Microcystic means something like you have greater than 6 cysts that are all smaller than 2 centimeters in size. These are highly vascular lesions, though benign, and these are most commonly seen in elderly females. Again, these are benign, so surgery should be avoided. MRI is often the most helpful imaging study for a definite diagnosis, and imaging features can include a central stellate scar and a lobulated contour. Next, if you see multifocal serous pancreatic tumors, what syndrome should you first consider? The answer I am looking for here is von Hippel-Lindau syndrome. If you see multifocal serous pancreatic tumors, that can be seen in the setting of von Hippel-Lindau syndrome. Also, if you simply see a true pancreatic cyst, von Hippel-Lindau should also come to mind. Next, what are key features of a mucinous cystic neoplasm of the pancreas? First of all, mucinous cystic neoplasms are premalignant lesions and are not always benign, unlike the serous cystic tumors. Mucinous cystic tumors are surgical lesions. These often have fewer and larger cystic components compared to the serous cystic tumors. Serous cystic tumors are most common in elderly females, and mucinous cystic neoplasms are most common in perimenopausal aged females. A key imaging feature is a fibrous capsule, and these are round or oval lesions and are characteristically not lobulated. Mucinous cystic neoplasms have an association with elevated CEA levels. Next question, true or false? Solid pseudo-papillary neoplasms, which are also sometimes called solid and papillary epithelial neoplasms, are most common in middle-aged females. Another name for this entity is also solid pseudo-papillary tumors, and this can sometimes be abbreviated SPT, solid pseudo-papillary tumor, SPN, solid pseudo-papillary neoplasm, or SPEN, solid pseudo-papillary epithelial neoplasm, or sometimes even papillary cystic neoplasm of the pancreas, and a few other names. I'm sorry there are so many names. The answer to the question, however, is false. SPN or SPEN, whatever you want to call it, are most common in young females to include teenagers. Next, what are classic imaging findings for SPN or SPEN? Again, the same entity. I will simply call it a solid pseudopapillary neoplasm. What are classic imaging findings for this entity? Classic imaging findings for a solid pseudopapillary neoplasm are an encapsulated solid mass with internal hemorrhage that is related to autoinfarction. Classic features for diagnosis are an encapsulated pancreatic solid mass with internal hemorrhage in a young female. Next, what is the prognosis of metastatic solid pseudopapillary neoplasms? The answer here is that the prognosis is often good, even if metastatic. However, these tumors should be resected as they are most often benign but have low-grade malignant and metastatic potential. Next, what pancreatic tumors have a capsule? Two classic tumors that are not encapsulated are serous pancreatic tumors and IPMNs. And an IPMN is an intraductal papillary mucinous neoplasm. Tumors of the pancreas that are encapsulated are mucinous, solid pseudopapillary neoplasms, and so-called sugar tumors. The best imaging study to evaluate for a capsule is MRI. If you see a macrocystic pancreatic tumor and it has no capsule, think of a macrocystic serous tumor. However, if there is a capsule, think macrocystic mucinous tumor. So again, the serous tumors are not encapsulated, whereas the mucinous tumors are encapsulated. Next, what is the cystic pancreatic lesion that is more common in males? The answer I'm looking for is an intraductal papillary mucinous neoplasm, more commonly referred to simply as an IPMN. These are the only pancreatic cystic lesion that are more common in males. This is the most common mucin-secreting tumor, and this is the only intraductal mucin-secreting tumor. Because this is intraductal, there is an association with elevated amylase levels and a high CEA level. These may be multifocal, and remember that other pancreatic cystic lesions are often not multifocal, and these are classically non-septated lesions. These can be further subclassified by location as either main duct or side branch IPMNs. And that leads us into the next question. True or false? Side branch IPMNs are classically associated with chronic pancreatitis. The answer is false. There is an association between chronic pancreatitis and main duct IPMN, but not side branch. Next, what pancreatic tumor is nicknamed the, quote, daughter lesion? Along those same lines, what about mother, grandma, and grandfather? I have already essentially covered this, but this is a slightly different way to think about it. So again, what is the daughter lesion, mother lesion, grandma lesion, and grandfather lesion in terms of pancreatic tumors? First, the daughter lesion is a solid pseudopapillary neoplasm. The mother pancreatic tumor is a mucinous tumor. The grandma pancreatic tumor is a serous tumor, and the grandfather pancreatic tumor is an IPMN, intraductal papillary mucinous neoplasm. Next question. What is the most common solid tumor of the pancreas? The answer is pancreatic adenocarcinoma. Next, what is the most common location for pancreatic adenocarcinoma? The answer is the pancreatic head. Therefore, look for abrupt pancreatic duct obstruction and vascular invasion surrounding the pancreatic head in the setting of pancreatic adenocarcinoma. Unfortunately, pancreatic adenocarcinoma has a high rate of vascular invasion and is unresectable at presentation in the majority of cases. Resectability usually requires that no metastatic disease is present, that there is only minimal to no encasement of the celiac, superior mesenteric, and hepatic arteries, and no contact with the superior mesenteric vein and portal vein, or otherwise contact that is mild enough that either the superior mesenteric or portal vein can be surgically reconstructed. Next, what is the most common location for a pancreatic neuroendocrine tumor? The answer is the pancreatic body and tail. These are the most common sites for neuroendocrine tumors, as these are where islet cells are present. Next, what are some of the most common pancreatic neuroendocrine tumors? The most common pancreatic neuroendocrine tumors in no specific order include insulinoma, gastronoma, somatostatinoma, VIPoma, and glucagonoma. These also have syndromic associations. On imaging for pancreatic neuroendocrine tumors, look for circumscribed solid masses that are encapsulated. Remember the potential role for somatostatin receptor imaging with gallium-68 dotatate PET-CT. A few key features in terms of pancreatic neuroendocrine tumors that I would remember for board exams. First, gastronoma in the pancreas should make you consider multi-endocrine neoplasia type 1. Multiple endocrine neoplasias are high-yield entities for the board exams, so you need to know these very well. But for now, remember that gastronoma in the pancreas should make you consider multiple endocrine neoplasia type 1. Also remember the association between a gastronoma and peptic ulcer disease, which is Zollinger-Ellison syndrome. And the cause here is gastronoma hypersecretion of gastrin that subsequently results in hypersecretion of gastric acid, which in turn can result in peptic ulcer disease, as well as gastritis, GERD, and diarrhea. And this also has a multiple endocrine neoplasia type 1 association. Whether evaluating for this entity on fluoroscopy or CT, look for thickened rugal folds. On barium, look for erosions and ulcers, and look for a nodular gastric contour. Also, remember that neuroendocrine tumors have hormone secretion, and when these are hyperfunctioning, these can cause various characteristic clinical symptoms. For example, with a VIPoma, these secrete vasoactive intestinal peptide, VIP, and this results in severe watery diarrhea and associated hypokalemia and achlorhydria. Next question. If you see a pancreatic mass in a young male of Asian descent, what is the top differential consideration for board exams? The answer I'm looking for here is a pancreaticoblastoma, which is classic in this setting. Look for associated elevated AFP levels. Classic imaging features of a pancreaticoblastoma are that of a circumscribed large pancreatic head lesion with internal necrosis and blood products. And a pancreaticoblastoma is the most common pancreatic neoplasm in childhood. Final question for this episode. True or false? Accessory splenic tissue can be located in the pancreas. The answer here is true. When present in the pancreas, accessory splenic tissue can look like a solid encapsulated pancreatic mass. Key features that can clue you into the potential for accessory splenic tissue is to look for signal and appearance that is identical to the spleen on multi-phase CT or MRI. And if necessary for confirmation, this could be done with a nuclear medicine tagged red blood cell or nuclear medicine technetium-99m sulfur colloid scan for confirmation. If the mass takes up either tagged red blood cell or sulfur colloid, that is imaging confirmation of accessory splenic tissue within the pancreas and not another pancreatic mass. That is a high-yield concept to remember for board exams. Thank you for listening to this episode. I hope that this has been helpful for many of you. Check out part 1 on pancreatic masses if you have not yet heard that episode, and feel free to download the free study guide on pancreatic masses covering the content from episodes 1 and 2 that you can access at theradiologyreview.com, along with other free study guides and educational materials. Also, while you're there, go ahead and check out the Radiology Review Journal, where there are several articles already present and more forthcoming, I promise. If you, listener, have an interesting story, thoughts on how to succeed in radiology, or vision into the future of what radiology may look like in coming years, you can also submit an article for the Radiology Review Journal, and more information can be found on my website, theradiologyreview.com. Keep up the good work and study hard. Remember, you have to study really hard to succeed on radiology board exams, so prepare to succeed. I will catch you on the next episode. Content of this podcast is provided for informal educational purposes only for radiology trainees and radiologists. Medical practitioners, please make your own independent assessment before suggesting a diagnosis or recommending any course of treatment. This podcast should not be used for self-diagnosis or self-treatment and is not a substitute for independent professional medical care. Please consult your own physician regarding any diagnosis, imaging interpretation, or course of treatment.